My name is Ana Aguilera. I serve as the Deputy Director for Adolescent and Youth Sexual and Reproductive Health and Rights at EngenderHealth. I have the great pleasure of being your moderator for this lively 1-hour session. And without further ado, to kick us off today, I'd like to introduce to you Tracy Baird, the President and CEO of EngenderHealth, to kick off this exciting session. So over to you, Tracy.
Greetings, everyone. I'm so pleased to be here. As Anna mentioned, I'm the President and CEO of EngenderHealth. And EngenderHealth is just so pleased and proud to be part of the Scaling Up Family Planning program. We value the opportunity to learn, to share, to grow, and together with our partners to have impact in Tanzania and Zanzibar through this important project. And so on behalf of the Scaling Up Family Planning Program partners, the Comprehensive Community-Based Rehabilitation Center in Tanzania, CCBRT, DKT International, my colleagues at EngenderHealth, and Pathfinder International, we want to really welcome you today. We're so glad you've joined us for this hour so we can learn and share together. And I also want to take a moment to especially thank our government colleagues and counterparts who are present with us today in this virtual session. Gerald Kiwele from the Ministry of Health in mainland Tanzania, Dr. Farhat Johar Khalid from the Ministry of Health in Zanzibar, Gertrude Mapunda Kudmunra and Jacqueline Fulgence from the Foreign Commonwealth and Development Office. And all of you, everyone else who's here, are very, very welcome. So as Anna invited earlier, please feel free to pop into the chat who you are, where you're calling in from, where you're joining us from. And really just thank you for being here. Thank you for being part of this. Thank you for learning with us, for sharing with us. And I'm very much looking forward to the session.
Thank you so much, Tracy. It is my pleasure to first introduce you to Gerald Kiwele, Coordinator for Gender and Adolescent Health at the Ministry of Health in mainland Tanzania, where he oversees all gender health response and adolescent health interventions in mainland Tanzania and a key partner to this program. So please, over to you, Gerald Kiwele, for opening remarks. Let's see. Oh, wonderful. I see you've joined us. Please go right ahead.
Yes, good afternoon. Good afternoon, everybody. My name is Gerald Kiwele, the National Coordinator for Adolescent Health and Gender, working with the Ministry of Health. First of all, I'm happy to be part of this discussion. And I would like to appreciate the support we are getting from as a government from various implementing partners, specifically EngenderHealth, Pathfinder, CCBRT, through this project of scaling up family planning with a big focus on strengthening SRHR services and gender responsive, aligning with the slogan of no one should be left behind. I understand the implementation of scaling up family planning aligns with our key national strategic documents. That's HSSP 5, 1.3, NAIA, the National Accelerated Action and Investment Agenda for Adolescent Health and Well-Being. With our guidance, scaling up family planning actually managed to support the capacity building to healthcare workers, CHW, social welfare officers on issues of youth-friendly services, gender-based violence and the violence against children, issue of family planning, just to mention a few. but also we did comprehensive integrated supportive supervision to the region where the project located. That's Geita, Morogoro, Tanga, Kilimanjaro, Arusha, and I think the Pwani. I understand there are so many things that scaling up family planning through gender, Pathfinder, CCBRT, they have done it with our guidance. And I know we are doing this because we are trying to address the challenge that we are facing in the country. We all know that the teenage pregnancy in Tanzania is alarming. It's 27%. The issue of GBV and the VAC, the issue of abortion, the issue of service delivery points, inadequate service delivery points rendering user-friendly services. It is a challenge. So having this kind of project, the comprehensive project, targeting youth, targeting survivor of FCDO, having inclusion services, actually gives us remarkable milestone and a remarkable milestone for our complementarity, the government and the implementing partners.
Thank you so much, Gerald Kiwele from the Ministry of Health. We seem to be having some connection, so we will hopefully be able to come back to you later on in the session. Thank you so much for your support. Next, I have the great pleasure of introducing Dr. Farhad Jawad Khalid from the Ministry of Health in Zanzibar, where he oversees the Integrated Reproductive and Child Health Program. So I'm going to pass it over to Dr. Farhad Jawad. Over to you.
Thank you very much. Thank you, everybody. Hi, everybody. Thank you for the opportunity to participate in this important 1-hour discussion session. As I've been introduced, my name is Farhad Khalid. I work at the Integrated Reproductive and Child Health Program within the Ministry of Health. I just want to let you know that sexual reproductive health, and in particular family planning, is a priority for Zanzibar and Zanzibar Ministry of Health. As currently our family planning services is a priority in terms of we are seeing it as one of the interventions that will help us to achieve our overall goal of the program of reduction of maternal and child mortality. So this is one of the very important interventions that your support is going to, and we really appreciate that. So the program that you are supporting us is helping us a lot, and it's complementing the government efforts in making sure that the access and utilization of family planning services in Zanzibar is increasing. And some of the support that we are getting from you includes the capacity building of staff, the supervision, comprehensive supervision of the services, and we do this in partnership, yourselves and us, and also you are also supporting us in service delivery, and all this support is going a long way in improving the family planning services. So we really appreciate it, and we are happy today to be in this discussion with how the program is going. Thank you.
Thank you so much. And now I have the honor to pass the microphone to Gertrude Mapunda Kungwara from the Foreign Commonwealth and Development Office, better known as FCDO. She joined FCDO in 2008, and in 2017 assumed the team leader role, overseeing the human development portfolio, which is inclusive of water, sanitation and hygiene, health, education, and social protection programming. Wow. Over to you, Gertrude.
Yeah, thank you. On behalf of the British High Commission here in Tanzania, I appreciate the opportunity to participate in this call, and the British High Commission is pleased to be supporting this important program, and pleased to see that there are lessons that are coming from implementation that we are able to share across and learn from each other, because it's through lesson learning that we are able to improve implementation of programs. As you're all aware, the program is building on a previous program and really focusing on addressing the issue of sexual and reproductive health in Tanzania, with particularly focus on women and men in rural and urban areas, young people and people with disability. So it's quite an opportunity for us to be able to, through this program and in collaboration with partners, to provide access to SRHR to as many people as possible, but particularly to groups that are usually being left behind, and that's young people and people with a disability. So thank you so much for welcoming us, and keen to hear what are the experiences that are going to be shared today.
Wonderful. Thank you so much, Gertrude. And without further ado, why you've joined us today to learn more about the first 2 years of this program, lessons learned, results, things we can share. I'm going to pass the microphone. We're moving into the presentation portion of this. After the presentation, we will be able to take questions and answer some of those. Please feel free to add your questions in the chat box along the way. And know we will do our best to get to all of the questions towards the end. So passing the microphone over to my colleague, Lillian Lukumai, Program Manager at EngenderHealth, to begin the presentation. So over to you, Lily.
Recording in progress. Recording in progress. Recording in progress. Recording in progress. Recording in progress.
Lillian, it seems we're having some, if you have maybe two computers in the same room, please mute the other one and only from the one you're speaking with. So maybe we can try again.
Okay. Having internet problem. Hello, everyone. Hello, everyone. Can you hear me?
Yes, we can hear you now. Great.
Yes, we can hear you.
Okay, thank you. So my name is Lillian Charles. I'm the program manager for the Scaling Up Family Planning here at EngenderHealth. So I'll be taking you through the health system strengthening component of the Scaling Up Family Planning project. Next, please, next slide. However, before that, I would like to share with you a snap of our service delivery model, because this program is both service delivery and health system strengthening. So before I take you through the health system strengthening, I would like to share with you our service delivery model. Next, please. I'm not seeing. So the program has three service delivery model. One is routine services, in which we attribute only 13% of the clients that we reach. And next is postpartum family planning, in which we attribute 55% of the client that we reach. And we also have outreach services. Outreach services is divided into three service delivery channels, which are family plan weeks, service days, and the integrated community outreach. Next, please.
So the picture you're seeing is one of the is the feedback meeting with the regional and council health management team in one of the region. So we're giving feedback after conducting joint supportive supervision and DQA. Just in a brief, during joint supportive supervision and DQA activities, we normally look into 3 components. One is supply chain, data quality, and clinical quality assessment. Next, please. So I'll be sharing approaches and achievements of the health system components that the program is taking. We have several approaches. One is the capacity building of healthcare providers and community healthcare workers to ensure that they have skills to provide quality sexual and reproductive health services. Another one is commodity stock level assessment to ensure health facilities maintain adequate stock for sexual and reproductive health supplies and equipment. And another approaches that we're using to strengthen the health system is to strengthen quality improvement structures of the region and the councils and the health facilities through training and mentoring during supportive supervision. We also conduct joint supportive supervision, as I said earlier, to ensure that to strengthen sexual and reproductive health services at the health facility levels. We also support collection and use of high quality data for decision making. And lastly, we do support service integration, including integration of COVID-19 vaccination into our outreach services. So we have achieved several milestones as highlighted, including training of more than 1,000 in these 2 years of project implementation. We have trained more than 1,000 healthcare providers and 235 community health workers in various components of sexual and reproductive health. We have also managed to support 8 regional health management teams and their councils to strengthen their quality improvement structure using national quality improvement framework. We have also managed to distribute various equipment for service provision, including postpartum family planning equipment for provision of permanent method, and post-abortion care services. Next, please. Next, please. So the picture that we're seeing shows various activities during our health system strengthening. One on my left is one of our program personnel handling equipment, and on my right-hand side, you could see our fellow from CCBRT conducting inclusive training, and the other one is the feedback session after conducting joint supportive supervision in DQA. Next, please. So in the first 2 years of project implementation, we have had several lessons. I'll share a few. We learned that joint supportive supervision provides avenue to support health facilities to provide quality, integrated, and inclusive health services, and it also has potential for sustainability. We've also learned that quality improvement trainings can help regional and council health management teams to establish quality improvement structures, both at the regional, council, and facility levels. Also, supply chain strengthening assists in identification and of stock gaps and timely redistribution of overstock commodities. And also mentorship and coaching are vital to ensuring high quality service provision. And last, the facility needs support to provide a comprehensive family planning method mix. Next, please. So challenges are unavoidable. So we have experienced critical shortage of service providers across all levels of health facilities, and we've also experienced periodic health facility and ministry staff reorganization, which affected skills for service delivery and oversights, and also inadequate financial resources to support. There's been inadequate financial resources to support sexual and reproductive health services and infrastructure improvement, and also inadequate skills and tools to ensure capture and report of key data. Next, please. So thank you for listening. I now welcome my colleague Shahada from Pathfinder to take you through the adolescent component of the program. Shahada, over to you.
Thank you so much, Lillian. My name's Shahada Kinyaga. I am the Scaling Up Family Planning Youth Technical Advisor working with Pathfinder International. And I would like to take you through how the program reaches adolescents. The picture you're seeing in front of you of very excited young people was taken after one of our in-school health session that was conducted in one of the schools. Next, please. So the program uses different approaches to reach young people. One of them is integrating youth-friendly services in all the training that we conduct, be it family planning training or GDD training, CPAC trainings, making sure that providers who are coming out of these trainings can also provide youth-friendly services. We also orient community health workers to be able to mobilize young people for outreach services and SRH services provided in routine. We also conduct outreach services that are adolescent responsive in facilities that are known to be youth friendly. So usually we identify these facilities and conduct outreach services that are adolescent focused in them. But then we conduct outreach services over the weekend to make sure that adolescents who don't have time during the week, either because they're at school or because they have other activities, can access sexual reproductive health services. But then another strategy is what we do is to strengthen the linkage between schools and nearby health facilities together with community health workers to increase access of sexual reproductive health services among in-school adolescents. Next, please. All these approaches have helped us to yield a number of achievements in the past 2 years. Some of these achievements include we've reached a number of people around 899 clients, and this is after attribution. We reach far more than that, but after attribution, it's where we get 899. And out of them, 13% were adolescents, the ages 10 to 19 years. And you will see later, but almost 75% of all the clients that we've reached were reached through outreach services. And then, of the clients reached through outreach, almost 14% were adolescents. We usually reach both adolescent girls and boys. And so you would see 96% of all the adolescents that we've reached through outreach were adolescent girls, and almost 36% of them were reached before getting pregnant. Two things here. One is that the program is reaching fewer adolescent boys, so there's a need to increase our reach to adolescent boys. But second, we're reaching more adolescents before their first pregnancy, which is very important in preventing teenage pregnancy, showing that we're reaching adolescent earlier. Next, please. Looking at the method mix, majority of the adolescents that we're reaching are opting for long-term method, implants, you can see, but then it's followed by condoms. Next, please. Lessons in the course of 2 years. One of them is, there's a need to advocate for increased health system investment in adolescent responsive services, making sure that adolescents can receive, privacy, time-specific services, etc. And then there's a need to strengthen linkage between schools, health facilities, and community health workers for sustainability, and to ensure that adolescents can continue accessing services in health facilities. There's also a need to strengthen systemic structures, existing systemic structure, than creating a siloed system, to ensure that there's a sustainability and this continues to live even beyond the program. But then we understand adolescents have unique needs, and therefore service providers need to be trained to respond to the needs of adolescents. Next, please. We've also experienced several challenges in the course of 2 years. Some of these challenges include negative attitude on family planning among gatekeepers. These are, teachers, parents, community leaders, religious leaders, hindering young people from going to health facilities or outreach to access family planning services. And what the program does is to try and, address this to parents who are visiting outreach services, try and talk to them. But then, we know health facilities lack infrastructure that are responsive to adolescents, reproductive health services, no privacy, there's no specific time for adolescent services. But then, providers lack trainings to provide adolescent-friendly services, and we have limited systemic investment, or less investment in adolescent-friendly services. Next, please. So I'd like to thank you for listening, and I would like to welcome my colleague, Frederick Nsigala from CCBRT, to take you through utilizing disability inclusive lens. Welcome, Fred.
Thank you very much, Shahada. My name is Frederick Nsigala. I'm the Technical Advisor, Disability Inclusion from CCBRT. And from the slide, you can see a picture which was taken in one of our facilities where we're providing education on sexual reproductive health with the support of sign language interpreter to try to address the barrier for communication, particularly for people with hearing impairment. Next. In our program, we have different approaches and they've made some achievement. The program employs like 6 strategies to try to reach people with disabilities. The first approach is to engage with the people with disability-oriented organization. These are organizations of people with disabilities which help us to mobilize people with disabilities to come for the services. Secondly, we are orienting community health workers to mobilize people with disabilities to come for outreach services. Thirdly, we have developed a screen tool to help us to identify people with disabilities, and this tool is being used by service providers in the facility to identify people with disabilities whom they are reaching with our services. We are also participating or engaging in people with disability-focused events, or like conference meetings or a marking of International Disability Days, where we provide services on sexual reproductive and family planning to people with disabilities. We are also training healthcare providers to provide disability inclusive services, and we have developed a monitoring tool to aggregate people with disability data so that we are able to track how much are we reaching people with disabilities with the services. Next. From the slide, you can see the method mix among people with disabilities, and this is the data from January to March in 2022. I would like to make note here that in the last 2 years, we are not collecting this data, but from this year, the first quarter, we collected this data just to see whether the impairment has an impact on the method choice among people with disabilities. And from the pie chart, you can see 78.6% preferring implant, and injectable is just like 9.1%. Next. In the implementation of this program, we've learned some lessons. One is capacity building on disability and disability inclusive services can help to achieve the goal. Most of the service providers do not have knowledge and skills on how to provide inclusive services. So we are building capacity to ensure that they have that knowledge to reach people with disabilities. But also we've learned that connecting with the people with disability focused organization and training community health workers to provide people with disabilities with information and services can improve demand and uptake of sexual and reproductive health care services. Also, we've learned that strengthening outreach services can reduce access barrier to sexual reproductive services, especially in remote and distant areas. We know one of the barriers for people with disability to access services is transportation. They have to cover for their own costs, but also they have to cover the costs for their personal assistant. So addressing this by outreach services, it helps them to get the services. But also we've learned that including a section on people with disability specific service provision in the National Family Planning Guideline and Standard could strengthen people with disabilities services. Next. Yeah, wherever you have achievement, there are some challenges. In reaching people with disabilities, we have noted the following challenges. One, few service providers trained to provide people with disabilities inclusive services. Thirdly, secondly, health information and education materials are not available in accessible format for people with disabilities, like in Braille for visually impaired people, or sign language for people with hearing impairment, or large print for those with hard of vision. But also health facilities like appropriate infrastructure for people with disabilities, particularly the old one, at least the new ones that are being constructed, they're now taking into consideration issues of ramp, and in some of the story building, they're also putting some elevator. But another challenge is that the current information management system does not include disability data. Then it becomes difficult to track how many people with disabilities you have reached and with what services. Next. Yeah, no, that's the end of my presentation. Thank you very much. I would like to welcome my colleague, Dr. Katanda, to take you through in integrated gender-based violence care into sexual reproductive health services. Dr. Katanda, over to you.
Thank you very much, Frederick from CCBRT. My name is Dr. Katanta Simonza. I'm the Senior Program Technical Advisor for Gender and Social Inclusion at EngenderHealth, and a safeguarding focal person for EngenderHealth Tanzania. So in implementation of our programs, we have integrated gender-based violence into provision of sexual reproductive health services. This is very important, as we all know the impact of gender-based violence in access of health services. We are working very well. We are working very close with the government by using the different tools which they have, including the GBV screening tool, in which when we are doing the screening, we are able to identify various types of gender-based violence, particularly the physical and emotional, and the Next slide, please. Yeah, as you have seen in the previous slide, the picture of one of our service provider, national trainer for the government, particularly from Zanzibar. She was conducting training for healthcare providers to ensure that they acquire appropriate skills in provision of service during implementation of our programs. So we use different approaches, as I mentioned, one of which being training, orientations, mentorship and coaching, using various opportunities, with the intention of building skills and knowledge for healthcare providers and community health workers. But at the same time, as a program, we have been able to advocate the use of GBV tools at service delivery point. And in another, at a point also, we are helping the government to develop the GBV referral trees for service directors. We are also analyzing the data so that to inform and for planning and for the future interventions. But also one of the key components which we are introducing as a program is the idea of safeguarding. So we have done orientation of safeguarding for all staffs, for our program partners, and we are also working very close with governments, healthcare providers to ensure they give this component's priority. As you see from this picture in the slide, the male involvement is a key point, as my colleague Shahada mentioned, especially for reaching adolescent boys is a bit challenging. So we are working very close with the community, especially community health workers, to engage male and to invite them in different service delivery points so that they can get the services, but at the same time, they can get the information. Next slide, please. So the key achievement for the implementation of the program for the past 2 years, this include the program have reached over 2.2 million of clients before attribution, over whom 285 clients were screened, and we were able to identify 70 incidences in which a few clients were given referral elsewhere for further management and clinical further management. During outreach services, we are also able to reach about 672 clients, of whom 247 during outreach were screened for GBV, and we were able to identify almost 1,000 GBV incidences were identified through outreach screening. So next slide, please. So the key lesson learned for the implementations of our program, one of which is it's very important to involve key decision makers in the government, especially regional and district nursing officers during program intervention, particularly supportive supervision. It has helped a lot in building the skills and knowledge of service providers so that they can offer high quality GBV care. But as a program, during the inception of the program, we worked very closely with the Ministry of Health to develop the standard package, which we are using to orient program staff, partners, and also trainers who are conducting various training during the program implementations, so that at the end of the day, they can ensure they are building skills for provision of inclusive services for clients who are attending the services, so that the GBV is also considered. We are ensuring and surfacing to our service providers that they should adhere to strict national GBV screening standard, which is helping in identifying various GBV incidences. And we really need also to, we really appreciate and register the strong commitment which we are seeing from GBV focal person at the Ministry of Health, both in Island and Tanzania mainland. Next slide, please. So the key challenges which we are seeing in integration of GBV into provision of SRH services, one of which is the existence of rigid gender norms, in which in one way to another, it's causing tolerance of GBV. But at the same time, the other big challenge we are seeing, GBV has been perceived as a supplementary intervention. So we are seeing lack of commitment sometimes of service providers. So there is a need of conducting training to GBV care. Service providers, and as I mentioned, and supervise, they need also to gain more knowledge and skills so that they can be able to coach and provide mentorship to others on how to use a GBV screening tool and provision of GBV medical care. And lastly, some of the facilities they lack GBV HMS tool, which is posing another challenge. And we are seeing most of the districts, due to the financial challenge during CCHP, they are not budgeting for production of HMS tool. So that's my end. That's the end of my presentation, and I would like to take this opportunity to invite my colleague Deus Ngelangela, so to take over in exploring key indicators and results for our program intervention. Karibu Deus.
Thank you very much, Dr. Katanta. My name is Deus Ngelangela, the M&E Manager for Scaling Up Family Planning Program at EngenderHealth. I'll be taking you through the program key indicators and results. The picture in the slide shows the feedback meeting after DQA and the support supervision activity in one of the facilities in Zanzibar. Next. As shown previously, the program reached over 2.2 million clients. Of those, over 899,000 were attributed to the program. However, of the attributed number, 75% were coming through outreach service delivery models. The point to note here is that the program is reaching far more clients through routine service delivery model, but with attribution, the overall contribution appears low. As you can see, for outreach service delivery model, 74% of the clients were coming through family planning weeks. Next. The slide shows the performance of indicators. Overall, the program surpassed all indicators milestones in the first 2 years of program implementation. For example, the program reached over 36% of its milestones for the number of clients reached, and over 200% of the number of unintended pregnancies averted. Others is highlighted in the slide. Next. Here, the slide is showing the method mix for all clients that we have reached for the past 2 years. As you can see, the implants remain a preferred method of choice for most of clients, followed by injectables. Next. Yeah, annually, we usually conduct client exit surveys to respond to our 3 indicators. And one of the indicators is the quality of counseling according to FP 2020. The second is the level of poverty, of which we are looking at the lowest 2 quintiles. And the last is the client satisfaction with the services. So as you can see in the slide, there is a tremendous improvement in the in year 2 of the between the 3 indicators, and a remarkable improvement is seen for the indicator of client satisfaction with services from 79% in year 1 and 92% in year 2. We also monitor factors associated with client satisfaction. As you can see, only 2 factors appears to be associated with client satisfaction: the cancelled according to FP 2020 and the level of education. Next. Lesson learned. The following are the lessons learned by the program in the past 2 years. One is that routine services saves more clients, as I've mentioned previously, but with the attribution, the overall contribution appears very low. The second lesson learned is that family planning weeks remain to be the main driver of outreach client saved, including adolescents, youth, and people with disability. Another is the commodity redistribution is critical to uninterrupted service provision. And lastly, the commitment of central government officials, region, and the council management team, and also staff at the facility is critical for this program implementation. Next. Okay, challenges are inevitable. The program faced the following challenge during the period. One is the low uptake of permanent methods. Second is the inadequate systematic financial resources to sustain family planning services. Another one is insufficient availability of HMIS tools in the facility, and lastly is the periodic reorganization of trained service providers. Next. Thank you very much, and I take this opportunity to hand over to Anna to continue with the next session of the presentation. Back to you, Anna. Thank you very much.
Thank you so much, Deus. And in 25 minutes, you have tried and succeeded in trying to communicate the complexity and the really important results, but also lessons learned and challenges that this project has faced and continues to face as we are implementing its third year. We have had a number of questions. Thank you so much to everyone. We are doing our best to answer the questions in the chat so that we can get to them, but I did want to take a moment and maybe ask Freddie a combination of a few questions that came through. It seems like there's a lot of interest in reaching people with disabilities. And so Freddie, I'm going to pass it over to you and ask, maybe you can elaborate a bit more on the specific approaches that the project has taken, maybe a few examples of reaching those with physical disabilities, maybe the process for adapting materials for specific groups, and how we've been able to really reach this group in spaces that maybe are not as open or friendly to them as other spaces and communities. So over to you, Freddie. Let us check that. Yeah, there you are.
Yeah, so the way we've been reaching people with disability, particularly with physical disability, and that said, the main challenge has been like to access distant, health facilities. So one is like the outreach, activities that are being conducted are normally conducted in rural places, in villages where people with disabilities are living. But also we're using community health workers who are at the community level. When we're having an event or an outreach event in that particular place, we use health community workers, we use local government leaders, we use leaders of organizational people with disabilities to mobilize people with disabilities to come to a particular place where the services will be provided. And whenever we are identifying a location where the places will be provided, we have to make sure that at least that facility has an accessible infrastructure. It might not like 100% accessible, but at least that a person on a wheelchair or someone using crutches can come and access the services. So we are like doing that to make sure that at least they get the services closer to them. In terms of like adaptation of the materials, it depends on the type of disability. For example, for people with hearing impairment, in some instances, we've been using sign language interpretation, but not always, because sometimes you might not get that opportunity of having a sign language interpreter. So we've been training our healthcare providers to use even the local traditional way of communicating with people with disabilities with the support from their family members. And most of them, they are the ones who are accompanying them when they are coming for the services. But also we've been training our health providers at least to use like lip reading, for example, and how to position themselves and how they can use body language to send the message to the client with the hearing impairment. So those are some of the techniques that we've been using to reach people with disabilities in different areas where we have interventions. Thanks.
Thank you so much. Thank you so much. We have a few other questions that we'd like to get to, and I think one, I'll pass it over maybe to Dr. Moke, who can share a bit more with us about maybe two pieces, and feel free to pass this along to other colleagues. But the first is looking at sustainability and health system strengthening. And someone is asking, it seems that the program's success is reliant on the training of health workers, and asking to what extent you believe that in the future, perhaps the government can offer these trainings and so it becomes a more sustainable approach, or is there other professional development plans in place? And maybe if you can talk about that for a bit. And then secondly, lots of questions are coming in about implants, and it seems that We have some answers in the chat about, what the comparison is of the method mix, and implants are quite highly preferred, it seems, in Tanzania in terms of what the national data systems tell us. But maybe share a little bit more about what we know about the high preference for implants and how our program is sort of measuring client satisfaction, but also informed consent and client choice. So over to you, Dr. Moke.
Thank you, Anna. I think one approach we are using to ensure sustainability when it comes to the training, we are not only training service providers, but in addition, training of TOTs. We have trained TOTs in almost every area we support, be it family planning, post-abortion care, and GBV. The aim is to ensure that there is a pool of highly skilled trainers to continue with the training or orientation of available service providers, even when the program was ended. On the question of preference of implants, appears to be preferred by more. I think this is the overall method choice for the country. It's not only scaling up family planning. We have reviewed data from other partners, overall government data across the country. Implants appear to be the most preferred method, although it could be for one reason that some years back, the government provided guidance to ensure quality on whether permanent methods should be done. And with a prescription that this is only done in a place with a functional theater. And we saw thereafter the uptake of permanent methods reducing slightly and the uptake of implants increasing. Although you cannot conclude 100% attribution, but we believe it might have helped some people to opt for long-term methods like implants than opting for permanent methods. But again, I should reiterate that when it comes to family planning, informed choice is important. If clients are opting more for implants, they should be given that chance to opt for something they require. There was one question, if you can allow to answer this again. There was one question from Dr. Ajay asking what's the prevalence of PWD in Tanzania. It's around 9.2%. Although I should clarify that the tool we are using for screening is a bit stricter than the usual tool used by the government in our previous census for assessing people with disability. And this was done in consultation with other stakeholders, including organizations involved in people with disability and people with disability themselves, to identify the level of disability likely to pose a challenge for someone accessing services, and hence the adoption of a stricter mechanism for categorizing somebody of having a disability. We included albinism too in this category, although in the available tool used by the government, adopted from the Washington criteria, doesn't have this criteria. Thank you. And back to you, Anna.
Thank you, Dr. Moke. I'm just going to pass it right back to you, as we are running a bit short on time for you to close out our session today. And I'd just like to formally introduce Dr. Moke. He's very humble. He is the program director and country representative of EngenderHealth in Tanzania. And so over to you, Dr. Moke.
Thank you, Anna. Let me take this opportunity to thank you all. I think words cannot suffice to thank you for taking part in this webinar. Thank you for your time. And specifically to our representative from FCDO, our gratitude for the trust and the guidance you are providing to us. Whatever we have shown here today wouldn't have been achieved without your guidance. To our colleagues from the two Ministries of Health, Dr. Farhat from Zanzibar and Gerard from mainland, what should we say? You have always been there guiding us to ensure that we contribute what we can to ensure our people get quality services, be it during support supervision. And lately, I should possibly say this, on mainland Tanzania, we are reviewing our FP guidelines and the standards. We have even included a component to cater for people with disability. The previous one didn't have this provision. Thanks to you all for this understanding. Understanding that people with disability, for instance, they need to be accommodated, leaving no one behind, as our HCP 5 says, is our motto. Thank you all, and wishing you again a wonderful evening or a wonderful morning, wherever you are. Back to you, Anna.
Thank you, Dr. Moke Mugoma. Thank you to all who joined. We will be sharing the recording and had shared a resource in the chat. This is the beginning of the dissemination for this program. And as we said, still underway. So please feel free to reach out to Dr. Moke directly. And please be on the lookout for more virtual and in-person events at the International Conference on Family Planning that is upcoming later this year, where the program will be present. So thank you so much and have a wonderful afternoon, evening, or morning. Bye-bye.
Bye.